basic essentials today, and little about Harsha and Malarpriya. So Harsha has about 10 years of experience, and he has worked predominantly in healthcare and life sciences. Malar has about 9 years of experience, and she has been a techno-functional BA. She has been a SME, tech lead, developer, and product owner as well. She has worked into different domain as travel and hospitality, trading, and currently she is working for legal domain. So let's. I would give Malar the podium so that she can begin with her intro. Thank you, Malar.
Thank you, Sai. Can you start?
Sure. Thanks, Mitu, for the intro. We can get started. So this is the first session on the PBM. Today we'll talk about PBM uh, overview, business model, PBM types, components of PBM systems, revenue, and PBM in market. So this is the first session where we will be, talking more on the basics of the PBM. We'll see some in detail on the revenue and components, and we also have a series of sessions planned on the PBM, and we'll be starting with them sooner. So this is the first one. Thank you all for joining. So the first one is PBM overview. So what is PBM? So PBM it serves as a middleman between insurance companies, pharmacies, and drug manufacturers. They are primarily responsible for securing lower drug costs or from for insurance and the insurance companies. And they accomplish this by negotiating with pharmacies and drug manufacturers. And these discounts are then passed to the insurance companies so that profits are generated through a slight upcharging of drugs or by retaining portions of rebate. So this PBMs in general, they have different roles in the US market, right? They act as drug benefit. They also act as drug benefit administration. They also participate in the formulary management, price negotiation, pharmacy network management, mail order and specialty pharmacy services, manage clinical programs, patient and provider support, reporting and compliance. So these are the different roles also which the PBM works. And if you see this slide, right, PBM, a person highlighted here in red, right, they are interacting. They act as as I said, like they act as a middleman between all the primary groups, the insurer or the consumer or the pharmacy, wholesaler or drug maker. So the role of PBM is very significant in the US market, and we will see that significance in the next slides. Malak, can we go to the next slide, please? Thank you. So first, let's try to understand why exactly this PBM is started. Yeah. So in 1960s, they were first formed as pharmaceutical card system to purchase medication using card systems, like how we have a debit or a card or credit cards, right? So, and in 70s, they have evolved toward diversified pharmaceutical services created by UHG, which is United Health Group, Healthcare Group now. And in the 80s, they evolved to pharmacy networks and also mail service benefits, and late real-time electronic drug claims, paperless drug claims, which gave boost to create as a PBM. So in the 80s, they have full-fledgedly whatever the primary functions they are making now, they are most of them are evolved in 1980s. And PBMs originally specialized in prescription claims processing, mail order pharmacy services, network design, and account management. As spending on the prescription medications grow, as population increased, right, PBMs became more involved in the management of pharmacy benefit spending on behalf of their plan sponsor clients. From then, PBMs have evolved to take on more business activities and meet the changing needs of clients. They were very agile and they have increased in different areas. And today, PBMs manage and oversee pharmacy benefits for 95% of the individuals with prescription drug coverage on behalf of employers or insurance, including Medicare, Medicaid, and private insurance. So, as I said earlier, they serve as a middleman between health plans and wholesalers or pharmaceutical companies. But primarily, they have two objectives. The first is reduce spend. PBMs negotiate pricing with a large network of retail or mail pharmacies due to their size, and thus they can leverage this the price negotiation. And PBM can also buy drugs from directly from the manufacturers at a discounted price. This enables them to offer patients and employers with greater access to medications across multiple retail chains with a competitive pricing. And their second objective is increase access to medication. PBMs increase patient access to medications by negotiating directly with manufacturers or wholesalers. And the negotiated discounts from the wholesale acquisition cost, which we call WAC, they get it with the quantity discounts that they are able to pass it on to their clients, which could be insurers or the pharmacies. This means patients are able to get coverage for a drug they need at a lower cost to the plan and to the plan member. And in addition to these two primary objectives, they also serve as advisor to employers by providing recommendations on different pharmacy plan designs, clinical programs, and more. And it is fair to think of the relation between the PBM, pharmaceutical manufacturer, and the employer a bit like a game of tug of war. Because the pharmacy benefits manager in the middle connected to both manufacturer and the employer, and is being pulled in both the directions with a goal of getting both parties a fair deal and offering solutions to minimize the prescription benefit costs. Malak, can we go to next slide? Now let's see how exactly in US a healthcare dollar goes. So we got this from AHIP, right? And if you see, this data represents how the commercial health plans spend on the premiums. This data includes basically the employer provided coverage as well as coverage purchased by members on their own. And this data is from the 2018 to 20, and the average taken for these couple of years benefits, right? And this percentages doesn't add up to 100% due to rounding, but when you see the overall, the medication and medical services, which accounts to 82.4 cents of the healthcare dollar. So, and in this 82.4, 22 more than 22 cents go to prescription drugs, and 19 cents used to pay in inpatient hospital costs, and 19 and 19.8 cents 9 cents used to pay for outpatient hospital costs, 11.8 cents used to pay for doctor visits, nearly 4 cents for federal, state, and local taxes, and only 2 cents used to pay for the prevention of fraud, waste, and abuse. And only 3.6 cents of every healthcare dollar will go towards health insurance provider profits. So that is the reason why we see the PBMs plays as a major role in the overall US healthcare area. Moving on to the next slide. Yeah. And who are the primary customers in the PBM area, right? So in the healthcare industry, we usually say three P's, right? Payers, providers, and pharmacy. And there are other players, right? So payers are actually, they provide the funding for the provision of the care, and providers supply care to the patients through a variety of primary and secondary care organizations and hospitals, etc. And patients are the members who actually receive this service from the providers. Products are pharmacies or medical products or drugs, and the regulators are the local bodies or the policy makers who actually regulate the US healthcare insurance. And when we see the payers part, right, we see private health insurers, managed care organization, Medicare, which includes Part A, Part B, Part C, and Part D, managed Medicaid, state Medicaid, TPAs, third-party administrators, which is employers, federal and state governments, and union-sponsored plans. So PBM are, if we see here in the middle, right, the Express Scripts, Optum, CVS Caremark, they, as I said, they act as a middleman in between the payers and the providers, right? And you see Express Scripts, Optum, Caremark, CVS, they are the PBMs primarily, and Pfizer, Novartis, they are the manufacturer or the provider or the drug makers. right? So uh, this is where they actually get the negotiate with the payers and also with the manufacturers and get the revenue. Yeah. Moving on. So uh, next is the regulatory bodies. Who are the regulatory bodies who, which actually regulates the whole PBMs in the US, right? The first is AHIP, which is America's Health Insurance Plans. The next is PBM reform. The major reforms are brought by the state and federal regulation policies. They actually take care of the formulary review committee to review the drugs as to what specify as part of the PBMs. The next is Spread Pricing Act. Spread pricing is a PBM practice of charging payers like Medicaid more than they pay the pharmacy for a medication, and then the PBM keeps the spread or the difference as the profit. So, Spread Pricing Act it ensures accountability of uh, the amount which is paid for the prescription drugs. The next is Oklahoma Patients' Right to Pharmacy Choice Act, and this act is to establish minimum and uniform access by patients to pharmacy providers, and it regulates the PBM industry and contains numerous provisions that protect patient access, their choice, increase transparency, and also prohibit anti-competitive practices. The latest act in PBM is the PBM Transparency Act of 22, which prohibits unfair or deceptive pricing practices, and it also have a control on the incentives, and a fair incentives are paid, and also the transparent PBM practices are followed, and it mandates the transparency. The PBM Transparency Act does that. So these are some of the compliance or the regulatory bodies in of PBM. Moving on, the next is PBM business model. So what is PBM business model? They actually focus on the four areas, right? You see the first four: the managing electronic processing of pharmacy claim, implement the pharmacy plan benefit, establish or operate pharmacy networks, and the last is establish pharmacy payment rates. Let's see in detail what are these each area they contribute to. First is manage electronic processing of pharmacy claim. So pharmacy claims are adjudicated in real time through coordination between the PBM and the pharmacy. This allows the patients to access their medicines quickly in most of the instances. And the streamlined nature of this process contrasts with that of the medical claims from hospitals or doctors' offices, which can takes months to fully process. Right. And the next is to implement the pharmacy plan benefit. PBMs conduct DURs, which is drug utilization reviews. We will see this is one of the component. Uh, some of these terminologies we'll see them in detail in the next PBM components. So DURs and PBM conduct drug utilization reviews and develop and manage the formulary plan, which determines whether a medicine is required by a patient's insurer, and also the level of cost sharing patients are required to pay to access their medicines, and any utilization management requirements, including step therapy, prior authorization, and quantity limit restrictions. The next area is to establish or operate pharmacy networks. PBMs use plan benefit design to incentivize members to use specific pharmacy by offering lower costs, so that they share or restrict coverage, and by the prescription only filled at certain sites, which is at certain pharmacies. And additionally, large PBMs operate their own mail order or specialty pharmacies, and they can give more incentives to the clients to use their internal network through internal network, and they also have the non-affiliated pharmacy, so that they get maximum revenue by operating the pharmacy networks. The last is establish pharmacy payment rates. PBMs establish the reimbursement rates paid to pharmacies that dispense drugs to the members. And this reimbursement rate may be different from the rate negotiated between the PBM health or for every drug. So in one pharmacy, maybe a paracetamol can get for few cents, for 4 cents, and in other pharmacy, less than that or more than that. So this PBMs actually have more control on that rates by directly having contact with the manufacturers. So the whole business model is operated in three ways, which is traditional, hybrid, and pass through. So we will see on these four areas, each PBM operates in different ways. So we'll see in detail of these three models in the next slide. Moving on, the workflow, right? So we have seen the focus areas or the major areas which the PBM works, right? Now the first we see is the formulary list creation. So this is one of the first area where the PBM start working on. Right from the formulary list creation, they start acting with the insurers, and the utilization creation on the utilization creation is how the drugs will be utilized, and the plan the drugs will be part of the DUR or the drug utilization overview, and then they design the plan benefits for the members, and then they negotiate the contracts with the providers, the pharmacies, and they also have the prior authorization maintenance to be done on whenever a member avail a service, how the prior authorization is maintained, and if a member is availing a services, how the claim verification is done and the claim adjudication. And once the claims are completed, they prepare the reports. I mean, they also participate in preparing the reports, and these reports are then sent to the sponsors or the insurers, and also with the manufacturers to get the rebates back. So these are the different areas or the components which PBM works, and this is a high level workflow. And the different components of it we will see in detail in the PBM components. But this is a high level workflow as a step by step process. Uh, Moving on, the PBM business model. So in the PBS business model, there we see there are different ways a PBM generates the revenue. So here we are going to see one example of the business model. This is a kind of traditional model I'm showing you here, and they are and in this example we'll see the the direct revenue to the PBM. There are different ways a PBM generates the revenue. Here we'll see the direct revenue of PBM. So you see three floors here. There are different actors here: the drug makers, wholesalers, pharmacy, PBMs, health insurance providers, and patient. And there are three different flows: supply flow, money flow, and negotiation. First, let's see the supply flow, which is highlighted in green, in blue here, right? So, supply flow is, when the makers make any drugs, right? They give this drugs to the wholesalers, right? The wholesalers will then distribute them these drugs to the pharmacy clients. Now, this is the supply flow. And coming to the money flow, whenever let's say a patient, right? So the money flow will start from the patient. So patient pays they co-pays for the drugs to the pharmacy, and pharmacy pays it to the wholesaler, and the money goes back to the drug makers. And the other flow is drug makers will have the contracts between the PBMs. They pay the rebates between the PBMs and drug makers. This is one flow. And also the PBMs get money through the health insurance providers. So when a patient enrolls with the insurance company, right, whenever they are availing any service, this health insurance provider, when they submit a claim, right, they once they get the final report, based on the report, the PBMs get paid on how many claims are closed, right? So, and also PBMs give they also have some discounts or negotiations with the pharmacies, so that some of the prescribed drugs are sold from the pharmacy. So this is the second money flow, and the third is negotiation. drugs. So negotiation drug is between the PBMs or the wholesaler. So PBMs and the wholesaler will have a contract that, this type of drugs we want to sell, so that they can generate maximum revenue out of this. So this is a business model. This is a traditional business model, I would say, and the revenue what PBMs are generating here is from the different ways, like right from the insurance providers and also from the drug makers and also with the pharmacy. So this is kind of both direct and the indirect revenue model or business model I'm showing you here, where the PBMs are generating the money. Moving on to the next slide. So let's take an example here, right? So we see a workflow of how in each and every stage, right? We have seen different members, different actors here: the pharma company, wholesaler, pharmacy, PBM, and insurer. At every stage, where exactly the pharma company, wholesaler, and the pharmacy is making the money, and PBM is making the money, and how the insurer is making the money in the whole system. So the first workflow is the one which is highlighted in green, right? So a pharma company, they uh, they manufacture a drug, right, and they decide the cost of the drug. Let's say $100. The drug maker lists the drug of for $100, and they make a list price, right? They make a list price which determines fees, rebates paid to the PBMs or insurance. So, and additional $10 is added to the by the pharma company, and they sell this product to a wholesaler for $110. Now, what does a wholesaler does? They add 10 more dollars to the product and make it to $120, right? And the wholesaler now sells it to the gives that $120 drug to a pharmacy. Now the pharmacy sells this finalizes the amount for a drug as $130, right? This is one flow where in each stage the pharma company is gaining some amount, the wholesaler adding some amount of $10, and pharmacy is keeping a $10. Now a member is purchasing a drug, right? They are paying $130. So if you see copay, the consumer is paying $20 as a copay, and PBM is paying $110. So overall, a pharmacy is getting $130 so they can dispense the product to a consumer. Now, consumer spends $20 and the PBM spends $110. So now coming to the flow, which is there in highlighted in the red. So now you see the pharma company, right from the pharma company, they are paying it to a PBM of $50 rebate, right? There will be a negotiation or the agreement between the PBM and the pharma company that they typically get a 10% rebate, but in this example I'm taking $50 as a rebate, right? So they keep the PBM keeps the $50 rebate, right? And this $50 rebate will be shared between the insurer, and this $45 is paid back to the insurer, and $5 is kept with the PBM. And when we see the insurer is paying $140, so PBM on the whole, if you see, they are making they are from the pharma company, they are getting $5, right? And the insurer is paying $140, but they are only paying $130. So here 30 plus the $5 from the pharma company, they are keeping the $35. And though the insurer at the first stage they are paying $140, they get a rebate of 45. So 140 minus 45, they are actually spending only $95. So this is how the insurer, the PBM plays a mediator between the in the whole process, so that $140 though they are paying, the $130 at a pharmacy, it is actually costing a insurer only $95. So everyone is paying fairly, right? And they are generating the money. So this is how the whole rebate works, and at every stage the different actor gets the money. Yeah, I hope it is clear, and then we can move to the next PBM types. As we have seen, the
Just
business
clarify
model.
one thing, if I may.
Yeah, yeah.
So basically, coming back to the next slide. Yeah. So basically, on the question who pays for the medication in the US, that means that everyone pays more or less, but it depends who keeps more or less, right? And also, where is the role of the typical user in this scenario then? Also, would be nice to go this part as well. Thank you.
Okay. Okay. So, yeah, when you say when you're asking from the consumer point of view, right?
That's true.
Yeah. So, the consumer, as part of their health insurance policy, right? They are agreeing only to pay a certain amount of copay, right? And if we when we have seen the workflow in one of the workflow in the previously, right? PBMs also work in designing the benefits in the overall in the overall plan benefit, right? So consumer can also have, in this case the consumer is paying $20, but there are instances that there is no copay. So it depends on the type of the plan which the consumer is availing from the insurer, and they get the benefit out of it. Is
Okay.
it clear?
Thank you.
And we are going to do a drug pricing session as well. Your question is valid, it is not always a consumer will get benefit out of PBM, right? So PBM can also do
Mhm.
some things which is not fair. So where, we have certain acts as well in place. That is why the acts were come into place where PBM making consumer pay more or insurer pay more, and they get lot of benefits, right?
Mhm.
So that is why those acts were coming into place. That is why even the PBM Transparency Act was there. So in our drug pricing session, right, so we will uncover what PBM can do unfairly, like what are the frauds that they can do and how the acts are preventing
Okay.
that. Okay.
Thank you.
Thanks, Manu. Yeah. So the next is coming to the business models. We have, as I said earlier, like we have three types of business models: traditional, hybrid, and pass-through. So you see a hybrid model just by the looking at the diagram that traditional hybrid model is a mix of traditional and pass-through. So let's talk about traditional model. So the traditional PBMs offer volume discounts and high rebates to achieve cost savings. They typically do not have any admin fee since they earn significant amount of revenue from the spread. And this model is less transparent about their business practices, and the fraudulent transactions or the practices happen here, and but it requires strict adherence to plan designs and contract details. So that's how the PBMs make more money in the traditional way. The next is I want to talk about pass-through model. So in the pass-through model, PBM focuses on the uh, focus on the pass-through of costs and revenue back to the plan sponsor. So model is fully transparent so that the PBM's business practices and all the fees charges are visible. Plan design and contracts are flexible because PBM's only source of revenue in this pass-through model is admin fee. Instead of generating revenue from rebates and pharmacy transaction, only administer is the process of pass-through model. The next last business model is hybrid PBMs, where they are across, as I said, the cross between traditional and pass-through. They earn less from the spread, but they share more revenue with plan sponsors. They disclose most of their revenue practices, but still they have fees or charges built as part of the contract. And these hybrid models may or may not offer contracts and plan designs, but they are flexible in a way. So these are the different business models we have in PBM. Yeah. The next, we can go to the PBM components. Malar, you can talk
Yeah,
through.
thank
Yeah.
you, Harsha. So you see, we have so many different components in PBM, right? So the first one is payer contract management. Yeah, so that is the first contract that PBM will make with payers. Yeah, so the payers are the one who will have customers who are subscribing to their plans. So then PBM have to make the contract with payer, and it they can choose any model, right? They can choose traditional or hybrid or pass through model. So based on that contract, they are going to generate the revenue. So in this contract, they will make notes such as, what are the services that are offered for this payer. For example, if EPAM is going to make a contract with any client, we will say, okay, development will be done by us and even production support will be done by us. So we will say something in our statement of work, isn't it? So in a similar way, payer and PBM contract will made in such a way that what are the services will be offered and what are the services will not be offered, and what is the contract period for it, and how we are going to generate the revenue. So everything is documented in this payer contract management. Okay, and moving on to the manufacturer's contract management and etc. Okay, so as I said as we said previously, so PBMs, the main purpose of PBMs is they are bypassing the payers and pharmacies and wholesalers, and directly they are making contract with manufacturers. Okay, sometimes they make contract with wholesalers, sometimes they make contract directly with manufacturers in a way that, okay, so we are going to place your drugs in the formulary. So if we are going to place your drugs in the formulary, you will get some customers, right? So based on that, you need to give certain amount back to me whenever there is a sale on your drug. Okay, so this is how the contract will be made, and the percentage is, once again, as Harsha told, more or less it is approximately 10%. But when it is a high cost drug or any cost, a different type of drugs, right? So again, the rebates and the cost pricing and everything will vary. Okay, so let's not go in deep dive because we have so many drug pricing sessions. And moving on to drug pricing. So okay, first they are making contract with payer, then they are making contract with manufacturers, and similarly they will make contracts with pharmacy chains as well. Yeah, and there are some PBMs who owns the retail pharmacy chains themselves. So that will be very easy for them to run their business. So when they have such kind of business, right, so they themselves involve in deciding the drug pricing. So but once again, they cannot decide any drug pricing by themselves. They are, what the purpose of PBM is to reduce the drug price. Yeah, so that is why we have PBMs in the market. So what is this drug pricing means here? Okay, so PBM will maintain a database in a way that it will develop their database from the DEA side or from the NDA side as well, and from everywhere. Yeah, and they will also subscribe to some third party systems called Medispan. So Medispan, what is the purpose of Medispan? We will talk more about different type of drug prices in our drug pricing sessions, but there are different formulas available in deciding the drug pricing based on the type of drug, whether it is a brand drug or a generic drug or a multi-source drug, or whether it is a high cost drug. So based on that, the formula for defining the drug price will vary. Okay, so this drug pricing formula is something that some calculation need to be made. We will see that in next session. But this formula is something that this PBM will do some modifications in this formula. For example, if you are going through certain pharmacy that PBM is offering you, for example, if you, the PBM will offer you a specialty pharmacy or a mail order pharmacy. So if you are going through the pharmacy that PBM is offering, the whole drug pricing formula will get changed. So both the customers as well as the insurers will get a different amount on what they would spend. Okay, so this is how they are managing the drug pricing section as well. And then moving on to the benefit design, consultation and implementation. So PBMs are not only getting the benefit design from payers and implementing in the system, but they will also participate in benefit design consultation as well. So PBMs, I was working in PBM for a long time. So on the behalf of every payer, we will contact some sales people as well, and then get our inputs. Then we work along with the payer to design our the next year's benefit design for some plans as well. Because since we have a good background background on how the claims are getting rejected, what type of claims that we are focusing, and we are also working in different kind of drug pricing, and we have a good knowledge with different manufacturers as well, right? So our points would be very valid when you're designing a benefit design for your pharmacy related plans. Okay, and moving on to formulary management. So formulary management means, generally, what is formulary? What is in, what is out? What is covered within the plan? What is not covered within the plan? But is it that simple? That is not. We have a separate session on formulary management where we will talk about in detail on how formulary is decided. But anyways, PBMs, what PBMs are doing in formulary management? You know, PBMs, when they are making a contract with manufacturers and different pharmacies chains, as I told you earlier, they will segregate the drugs in a way that they will create a different kind of list. For example, if you are using Amazon or any other services, you might notice that they have this tier 1 service, tier 2 service, tier 3 service, tier 4 service, yeah. And for each and every tier, it will have a different cost. And you can go with some kind of package as well. For example, if you go with professional package, then you can get multiple tiers. And if you go with a basic package, or a low level package, then you can get a different tiers as well, right? So in a similar way, formularies, a different kind of formularies will be built by PBM, and whenever they are contracting with payer, they will showcase their formulary list, whatever they have built to the payer. Okay, so the payer can choose like, okay, I want gold one, I want platinum one, so they can choose like that. Or otherwise, if payer wants a customized formulary, PBM can also work in building that customized formulary. So formulary management is not just a simple task. So many things will get involved. So it is not easy to cover within one session. So we'll take a separate session on formulary management. Okay, moving on to mail order and specialty pharmacy service. So PBM themselves run this mail order pharmacy and specialty pharmacy services. If, for example, if you take CVS Health or Walgreens, they have their own mail order and specialty pharmacy services. Yeah, if they will add this into benefit design as well. So if you just go to normal retail pharmacy, if you have to pay $5 copay, but if you choose a specialty pharmacy or mail order pharmacy, not a specialty pharmacy is for high cost drugs. Let's leave that. But if you choose some other pharmacy that PBM is offering you, you may see that there is a good dip in the drug price as well. Okay, and moving on to utilization management. So as Harsha was telling, so utilization management will control, like, is this particular drug, the people may claim for different drugs, but utilization management has a set of rules. It will decide whether this patient necessarily need this medication for this diagnosis or not. Okay, so those kind of rules will get involved in utilization management. Again, we have a separate session on utilization management. We have a separate session on drug utilization review as well. There is a slight difference between utilization management and drug utilization review management. Utilization management is just focusing on quantity limits, age restriction, gender restriction, and step therapy, prior authorization, and all these things. Drug utilization review is something different. So where you are, for example, let me take only one example, given the taking time into consideration. So you may going through some kind of therapy. Okay, for your diagnosis, you may be going through some kind of therapy, but that therapy consideration, if you may now go to a doctor and visit for some headache or any stomach ache or for anything else. Okay, they might prescribe you some medication. If you take that medication, your immediate problems will get resolved, but your therapy will get affected. Okay, so in that case, utilization management rules will not cover that. Okay, but drug utilization review has a patient care rules as well, so it will cover that. If there is a drug that you are claiming for, and the drug is having some contradiction with your therapy that you are taking for a long time, it will straight away reject the claim, stating that, okay, you have this therapy in place, so we cannot process this claim right now. And it will again send this rejection will be sent to the provider, and provider can reevaluate it. Then they can prescribe you the right medication. Okay, and moving on to the claim processing, as we were saying from the initial stage, like, so PBM handle all the pharmacy claims on behalf of a payer. So whenever a pharmacy is submitting a claim, it will not directly get submitted to payer. Instead of that, it will get submitted to PBM. based on the contract, of course. So the PBMs will process the claim and send the claims response to the pharmacy on behalf of the payer. Okay, then how are they managing, how are they reporting it to the payers or any of the sponsors, right? So there is a special module called PDE reporting, especially whenever there is a Medicare or Medicaid related claims. So we have to do the program drug event reporting. So that means for every claim processing, we need to generate the report, and there is a special standards that is available on how do we generate this report as well, and that will get updated so often, so we have to keep our system in a way that if there is a different requirement for this PDE report, we have to update our system as well in a way that we can generate the PDE report quickly if there is any change request that comes from the government. And managing clinical programs, as I said that, so PBMs are not only working with payers or just working with manufacturers. They will also help in managing different kind of clinical programs, patient care programs, provider support, patient care support, even all that. There are some PBMs available who are also installing some like a medical checkup and all this kind of stalls at different places to help patients. Yeah. Moving on, this claim processing. Because when I say claim processing, is it that too complex? Why a payer need a PBM to handle it, right? So let us see what the claim processing engine of PBM does. Okay, so when a claim is entering the system, first we need to validate the claim format. Yeah, because pharmacy claim need to follow NCPDP standards. Yeah, so currently most of the system follows D.0, but the future is F6. But yeah, for now it is D.0. So we will validate the claim format. So we need to develop the engine in such a way it will validate the claim format and reject it right away. And after that, eligibility verification. That is whether this patient is eligible to get this benefit or not. So we will write the business rules with the benefits, right? So we will do the eligibility verification. Then pharmacy service type and patient residence verification. That is, there are certain drugs available. You can get the drug only through home infusion or only through long term. If you are a long term care patient, then only you can get the drug. And certain drugs can be availed only through mail. So there are different kind of things available, right? So those kind of validation check will happen in the third stage. And in the fourth stage, again, the validation will made like whether this is a duplicate claim or whether this is whether they are able to get this drug. Maybe that patient may be a long term patient and they need to get their refill every 3 months once. But if they come before 3 months, then we need to tell them your refill threshold limit is not met. Yeah, so those kind of validation will happen. Then the pharmacy validation, whether this pharmacy is eligible to dispense this medication to this patient or not. For example, if the drug is a very classified drug, okay, so for example, if it is a morphine drug or any kind of classified drug, then they need to get a DEA license and then only they can dispense it. And also there are some pharmacy which will be blacklisted by the government, stating that okay, hereafter this pharmacy is not valid. Then PBM will also maintain the databases with the government, as I said earlier. So they will validate the pharmacy, and similarly they will validate the prescriber as well. Then they need to retrieve the drug information from all this government database. They need to check as well the drug coverage status check, whether this particular drug is covered or not. The formulary check. And then drug utilization review, whether all these claims are aligning with the drug utilization principles that we have. And utilization management edits verification, the drug have to pass the drug utilization review, then utilization management edits verification. Then if all these 10 points passed, then this claim will go through the adjudication. Okay, so in the adjudication, they will calculate the claim price, the drug price, and what payer should pay, and what PBM should pay the pharmacy, and what copay need to be collected from patient, and there are some Medicare and Medicaid plans available where there will be some discount from the government themselves, and there can be some there is a mandated discount by manufacturer if the patient is in the catastrophic phase of Medicare plan. So all these discounts and all these things will be calculated in this stage. Then finally they will send the member cost share and payer cost share calculation back to the person who requested this claim. Mostly it is pharmacy who submitted the claim. They will send the response back to the pharmacy. Then finally, the PD reporting is the last one. For every claim event, we need to generate the PDE report. So this is how complex the claim processing engine is. So that is why we have PBMs who will manage the whole claim processing on the behalf of payer. Okay, moving on to the next topic, PBM systems managing revenue.
Yep. Thanks, Millard. So now let's see how exactly the PBMs generate the savings. So first we'll talk about how do they generate the savings and in which different areas they get the revenue. So we have differentiated these 7 categories as a primary areas where they uh, produce savings. But I see a hand raised, Abhishek.
No, it is a mistake. I am not sure why it is getting up again. Sorry for that.
Okay, no worries. Yeah. So the first area where they produce savings is negotiating rebates from drug manufacturers, as Muller mentioned in the Muller mentioned previously, right? So negotiating PBMs negotiate rebates from manufacturers.
I think we lost Harsha, isn't it? Or is it only for me?
Hello,
Yeah, Harsha?
can you hear me? Yeah,
Yeah,
can you hear me?
you're audible. Yeah, you're audible.
Okay, okay. Sorry, thanks. So the first one is negotiating rebates from drug manufacturers. PBMs negotiate rebates from
I think there is some network
drugs and
interruption.
generics.
Harsha?
Can you hear me?
Yeah, you're audible now.
Oh, sorry.
Harsha,
Yeah.
sorry to interrupt, but you will have to repeat prior two sentences as there was some static so that it makes sense.
Okay, sure. Thanks,
Okay.
Neetu. Yeah. So in the PBM, how do they actually generate the revenue? So there are these are the 7 areas where they actually focus to produce the savings. Yeah. So now negotiating rebates from drug manufacturers. So drug manufacturers could be, the brand product manufacturers and also the generic product manufacturers. So brand drugs are costly, right? And the generics are a little less cost. So they PBMs negotiate this rebate amount. So the brands.
I think there is some network interruption. Maybe I'll take it forward.
Yeah.
So PBM
Thank you.
tools focus on the 7 primary areas for producing savings. Yeah, as I said previously. So the first one is negotiating rebates with drug manufacturers. As I said earlier, how are they making contract? And then based on the contract, we have shown one example as well, right? So that is one way. And another way is negotiating discounts from the drugstores. There might be the wholesalers or anyone, right? So we can make some discounts from them, stating that okay, so we will make your pharmacy into our place. So if we want to do that, then you have to provide certain discounts. Okay, so we can make such discounts. I mean, they can make such discounts as well, and offering more affordable pharmacy channels. As I said earlier, take an example of CVS or Walgreens. So why are they? If you just Google what is CVS pharmacy and Walgreens pharmacy, they have a very big chain of pharmacy, and they have all different type of pharmacy, starting from retail, specialty, mail order, so many whatnot. But why are they doing this? The main thing is that they want to make this pharmacy channels more affordable. Okay, so if they are going and making contract with some other pharmacy channels, maybe that is not affordable. Okay, so that's why some PBMs taking the pharmacy channels by themselves, so that they can provide more affordable pharmacy channels. Okay, and encouraging the use of generics and affordable brands. How are they encouraging the use of generics and affordable brands? With the help of utilization management. So we are talking about utilization management, right? So they will create a utilization management principle, but then don't worry that the utilization management principle is being overutilized by the PBM. So there are certain rules available, and government also will get involved in reviewing the utilization management rules and drug utilization review rules, and then only it will get approved and it will get implemented. Okay, and reducing the waste and polypharmacy, of course, and reducing the waste and improving adherence. Yeah, all this are involving in reducing the waste. So how can they reducing the waste? As I said earlier, in the claim processing engine, you might have seen different kind of steps, right? So why do we have all these checks? You might notice that you have to pass 10 steps to go into the claim processing. So that may be overwhelming for you, but why are they doing that? Just to reduce the waste. Okay, if you reduce the waste, automatically it is an indirect revenue for you. Yeah, and managing the high cost specialty medications. So managing high cost specialty medication is a separate topic altogether on how are they doing it. So it is not only with the utilization management principles, but also with additional benefit implementation. For example, while I was working in PBM companies, so there is a special team available to just manage the specialty medication rules engine. So that team is dedicated for managing the specialty rules engine. So they will develop different kind of rules, and they will propose that to payers, and after the approval we will implement that in the system. Okay, so whenever we hit the specialty drug, so we will capture the specialty drug by capturing, it will hit the drug list so that we can capture the specialty drug list. So after that we will apply the principles that we have defined with the payer, so that it will be delivered to the patient immediately. But then it should help the payers as well as the pharmacy in reducing the waste as well. So that is one thing. And another thing is that for the high cost specialty medication, we are providing some kind of a funding as well, because there are some drugs available which is like a $1 million for just one medicine or one pill. Yeah, so in that case, PBMs and the pharmacy channels that PBMs are providing, they will offer enough financial aid to the patient, so that they can use the drug but they can pay later as well. Yeah, moving on to the pharmacy benefits management revenue by major
Yeah.
categories. Do we have Harsha? Yeah,
Yeah,
go
yeah.
ahead.
Thanks, Malar. I'm sorry, there's network issue. So we have segregated this revenue into five types: rebates, spread pricing, fees, Medicare prescription drug plan, and specialty pharmacy. We have seen earlier the rebate. So what exactly a rebate is? A return of amount of from the original payment for service, right? So we have seen in the previous example that uh, the company, pharma company is directly paying $50 of rebate to the PBM. So from the actual amount of $100 or so, there we $50 is paid to the PBM. So that's a rebate. And the next is spread. Spread is basically it occurs when this PBM charge health plans and payers more for a prescription drug, and they reimburse to the pharmacy. So they pay more to the pharmacy, and the difference of the amount difference of the amount is shared between the insurance providers, and get the revenue. So that's called spread. And the fees is nothing but administer fees. Here PBMs also act as a admin fees or adjudication fees or processing pharmacy claims on behalf of the payers or sponsors, right? So they generate revenue also from the fees. Medicare prescription drug plan. So some of the PBMs also have the prescription drug plan, so that only some amount of or some certain drugs will be given to the members, and they get maximum revenue out of that. And the last is specialty pharmacy. Some of the large PBM players, they have their own retail outlets in the US, and they generate money from the specialty pharmacy. And if you see the numbers overall, right? So rebates, 25% of the majority of the companies get 20 revenue through rebates, and spread pricing. So CVS, one of the major player in the PBM, they get 11% through spread pricing, and Express Scripts 30%, and through fees, Express Script gets 25%, and through Medicare prescription plans, CVS gets 11%, and through specialty plans, specialty pharmacy, they get 30% of the revenue they generate. CVS generates, and nearly 20% Express Scripts generates through specialty pharmacy. So these are the major revenue categories we have in the PBM generating revenue. Moving on to the next is direct revenue and indirect revenue. So earlier we have seen in the business model, PBMs generating the money flow, right? So here you see in the direct revenue, PBMs are directly having a contract between the plan sponsor here, right? You see there are three flows here: product flow, funding flow, and service flow. In the product flow, a plan sponsor will have a direct contract between PBM, and they pay a pharmacy premium to the PBM. And the funding flow will they will also get from PBM will get from manufacturer, pharmacy, and health plan. And the PBMs give the service because sponsor is having a contract between the PBM, so they provide service. So this is the direct revenue generation by having an agreement with the plan sponsor. The next is indirect revenue in the PBM. So here, PBMs doesn't have any relation with the plan sponsor, but they have contracts between the health plans. They create health plans and give it to uh, and they give it to sponsors, and manufacturers will have a PBM agreement between the PBM, and they give rebate. Pharmacies will pay the amount also to the PBM. I mean, PBMs gives a discounted reimbursement to the pharmacy. So this is the indirect way of generating revenue to the PBM. And the next is moving on to the market. What are the different PBMs in the market? So Malaj, you can take it from there.
Thank you. Thank you, Harsha. So why do we need PBM, right? So when Harsha was talking about that flow where pharma company is making some amount, and wholesaler is making some amount, pharmacy is making some amount, you might get a thought that why can't payer just do this contract with pharmacy, contract with the manufacturer, and why can't they do that directly? Why do we need PBMs, right? So the first thing is that when we said about history, so PBMs, after PBMs comes into the place, since they have wide knowledge in the drug manufacturing and drugs as well, so they were able to set a low price for certain drugs. If you just Google it, so there will be some news circulating that only because of PBMs, drug price of insulins got reduced in US only because of PBMs. Okay, so wherever there is a high cost branded medications, PBMs negotiate with the manufacturers, and also they also develop that chain of pharmacy and different kind of services. So with that, they were able to provide the drugs in a more affordable way, sometimes even like a financial aid. They can get the drug and they can pay later as well. So all this services that they started, and after that they bring in all these principles such as utilization management principle, drug utilization review, and some special engines. For example, if you take CVS as an example, for maintenance drug they have a separate engine, and maintenance drug how maintenance drug will process, how specialty drug will process, how vaccine drug will process, for every category they have a separate engine to work on. So why are they implementing such kind of things? To make to reduce the cost and to provide the more efficient and more easy access as well. Okay, and especially when you take one example of this prior auth maintenance, so that is like a headache even till now. If you want any prior auth for a certain drug, if you just submit your form to payer, you have to wait at least nearly a month to get that prior auth approved. Yeah, but with PBMs in place, you can get this all this approval, and even the drug processing, everything will happen within seconds, within minutes as well. So that is how PBMs are helping the payers and as well as the overall US healthcare. Okay, and moving on to the leading key players in this market. So these are the key players in the market, and you can see the top three players: CVS, Express Scripts, and Optum Care. So they are the top three players in the market. You can see that if CVS Caremark themselves is holding 33% of the whole PBM in the United States, and CVS is the one top most ranked largest PBM. And what is the model that they are following? They are following the hybrid retail slash PBM model. So that means we'll see they are stacking in further slides. But what Express Scripts is doing, they are generating the incentives through their mail channel. So as I said earlier, so PBMs will develop this mail services and specialty services through which they can generate the revenue as well, right? So that is not only helping PBM, that is also helping the people, the consumers as well. So if you go through mail channel, you will get the less copay. So obviously you will go to mail copay, and they will also get the revenue out of it. And United Health is operating in a manner of medical slash pharmacy benefit model. So we'll see about it in the next slides. Okay, so here you can see CVS recently acquired 8 now. So instead of just going with only PBM, now CVS will go in a manner that they are also they also own a big retail channel, and as well as they are a PBM, and they have now insurance as well. Yeah, so they can develop plans, and they can be both health plans plus retail pharmacy providers as well as the PBM. Okay, and if you see United Health's or Optum's business model, they go with insurer plus PBM plus provider, right? So they choose a different model. And Cigna, you see, they are just insurer plus PBM. And if you see, this is a complete standalone PBM. So there are so many standalone PBMs as well, where payer can go ahead and make an agreement. Even with CVS, any payer can go ahead and make a contract with them. And CVS has lot of clients. CVS has nearly 80 to 70 health insurance. I mean, only from Medicare side, they have 80 to 70 health insurance. They are having a contract with CVS. Okay, so similarly for any PBMs that is listed out here, anyone can go ahead and make a contract with them. But then looking at their business model, how are they going to grow? How are they sustaining themselves as a topmost PBM, or a second placed PBM or third place PBM? How are they doing it? They are not only doing the PBM business, but they are stacking up them itself in a different way, so that they can grow in a different kind of way. They can generate the direct revenue or indirect revenue, so they can stay on the top. Yeah, so that's we are at the end of the session. If you have any questions, please post, we can answer it.
Yep.
And thank you so much.
Thank you for your time. Please do post all the questions in the chat and we would get back to you. Thank you, Malla. Thank you, Sai. Thank you,
Thank you.
everybody.